All right, so welcome back, people. We are on week 4. Again, we had just started lecture exam 2 material on Tuesday, and we were going through cardio phys kind of in an unusual way. We weren't just clicking through the PowerPoint. Basically, what we were doing was we were extracting a lot of some of the basic cardio anatomy and physiology out of the PowerPoint. So that way today we could separate it from some of the pathophys. And I think it's just easier to understand that way. Let me give you an idea of what I'm talking about here. But today, before I switch screens, we are going to be still working on cardio phys. This is where all the information is coming from. So when I make exams, the test questions are coming from the PowerPoints. So what we are shooting for is this week, again, we're covering our cardio phys PowerPoint. Next week, we're working on blood flow and pressure, respiratory system and gas exchange, and that'll tie up all the information that we need for lecture exam 2, which will be similar 50 questions, multiple choice, covering those 3 PowerPoints. So this week, we're working on the same PowerPoint twice. Next week, 2 separate PowerPoints, but between those 3, cardio, blood flow, pressure, respiratory system, and gas exchange, that'll make up our next 50 question exam. So what I was talking about is on Tuesday of this week, rather than just scrolling through the PowerPoint, what I tried to do was extract some information. So let me show you on paper some of the things that we covered. Like one thing we covered was, blood flow through the heart. And the reason we did that with our little circle diagram was it's good to show all the components of a normal functioning heart. And what does it take to be a normal functioning heart? I mean, your 2 pumps, right? Both pumps working simultaneously yet independently of each other, because one is concerned about bringing deoxygenated blood in, from the body, taking it to the lungs, and the other one's taking oxygenated blood from the lungs out to systemic circulation. So, if anything's wrong with this basic setup, that can cause a problem. So when we get into so on Tuesday, we went over some of the basics. Today, we're going to work on some of the problems. So for example, one of the first problems we might talk about is some type of maybe congenital defect. Like if this isn't set up ahead of time the way it's supposed to naturally be built, that's obviously going to create a problem. So one of the first things I'll mention to you today is, failure for these septum to close. So if you end up having what's called like an interatrial septal defect, that's a problem with the basic setup of the heart. So essentially in this case, this is a congenital defect because it's usually something somebody's born with. And it can form in 2 different ways. I think maybe one of the first 2 or 3 pages of the PowerPoint covers this. It's something called a patent foramen ovale or interatrial septal defect. And it's basically just the wall between the 2 atria, the right and left atria, are not closing appropriately like you should do after birth, right? So that could end up being a problem. Other things that we talked about when we got into some of the basics, not only did we do anatomy, because this actually covered quite a bit, we started getting into the physiology and stuff like that too. So we talked about like systole and diastole. Both of those things are just good to understand. And this is, not necessarily going to be in the exact same order that we covered everything. But we talked about cardiac output equals stroke volume times heart rate, cardiac output equals metabolic demand, cardiac output equals venous return. Because when you get into the physiology of things, your heart's trying to refill and pressurize blood. So we want to have enough blood to push out to systemic circulation, and we need to be able to forcefully push it out. So we need the blood to come in, fill these chambers, and then force it out against something called peripheral resistance. So you have this refilling phase, and then you have this contraction/ejection phase. And we have to keep up with the body's demands, when we're doing that. So at rest, the body's demands are fairly low, so the cardiac output can remain fairly low, about 5 liters per minute. But as the metabolic demand goes up, the cardiac output has to equal that, right? So ways we can alter cardiac output, using various different things like, so we talked about input versus output. And again, we did the input and output before we did this, but if I were to employ more like sympathetic innervation, for example, so sympathetics versus parasympathetics, this is going to decrease cardiac output. This is going to increase cardiac output. What are ways that I could increase cardiac output? Well, let's look at one of these formulas. One thing we could do is we could increase heart rate, leave stroke volume alone. Another thing we could do is increase heart rate and increase stroke volume by increasing heart contractility. And then another thing we could do is we could increase heart rate, we could increase contractility, and then we could also preload the heart more, right? And as we preload the heart more, that's going to cause more distension. The heart's going to naturally snap back with greater force. And then that's also going to contribute to the stroke volume. So again, all this can be achieved just by employing, sympathetic innervation, like things like epinephrine and norepinephrine can do all that. And you can actually get drastic changes in what your cardiac output is versus, when you're resting versus doing vigorous activity, right? Because we have these different variables we can play with. So that, again, was kind of some of the basic physiology. It never seems very basic at the time, because, you start throwing numbers in there, like you have 135 milliliters in there. And if I'm only ejecting 70 with normal contraction, how do we get the rest out? Well, you just contract harder. So it's basic stuff. But again, when you start throwing numbers in there and formulas, everything looks more complex than what it actually is. But again, today, when we get into some different problems or pathologies or diseases that the heart experiences, what if the heart can't meet its own metabolic demand? Why do we need to meet metabolic demand of the body? The body needs oxygen, like what are some things that are required for metabolic demand? You need oxygen, you need nutrients, and you combine those things together to make energy, right? So the body has the ability to maintain homeostasis. And that's what metabolic demand is. It's the need of energy. That's the demand. I need the energy to metabolize, right? Or I need to metabolize to make energy. It's both. But that energy is usually going to be provided mainly through the aerobic respiration of glucose. So we need to get oxygen to the cells, so it's more aerobic. We need to get the sugar and vitamins and minerals to the cells so we can run things like Krebs and glycolysis and electron transport chain and whatever else we need to run. And the blood's what's going to be carrying all these things. So the heart has to be able to pump that blood adequately to the body. But the heart itself is a very metabolically demanding organ. So what if the heart doesn't get enough blood itself? Well, you can get ischemia, you can get infarction. So you can have problems like a heart attack, right? So you could have a problem here, right? So you can have things like heart attack. And what leads to a heart attack? Maybe some type of heart disease, right? And of course, that's supposed to be an A right there, right? And then, this can be changed. We can have different problems with the heart where, we're not able to generate stroke volume as well as we used to be able to because of changes that occur in the heart. So as we go through the different problems, which I will list these out for you in just a second, it's showing you how these things can fail. And it just makes these things more realistic, more, I guess, familiar, because most of the time we aren't so familiar with normal. We're more familiar with abnormal because you hear about abnormal more because it's important, so if somebody's having a heart attack, everybody knows that. But, what is that really affecting? What is it really doing? Is it a permanent change? Can it be fixed? All that kind of stuff. So that's what we're going to talk about today. And it just makes the normal stuff more attainable, I think. So overall today, what we're going to do is we're going to be dealing with some type of heart pathologies, in some way, shape, form, or fashion. So first thing I'll talk about just real briefly is maybe some congenital changes. So if we have an intraatrial septal defect, what would that equate to? How would that show up in the patient? What is it basically? Another one we're going to talk about because it's a really popular, I guess, standardized test question is aortic stenosis. Because aortic stenosis, even though you don't see it a ton in people, it's going to have a very predictable outcome. It's going to cause very predictable changes in the heart. So if the opening that I'm trying to push into from the left ventricle is too narrow, by design, it just didn't form appropriately, then you're going to obviously see certain predictable changes in the heart. So it ends up being a pretty popular standardized test question, even though it's not the most popular condition. We'll talk about heart disease, what that word means, and most of that focus is going to be on coronary artery disease. We'll talk about how coronary artery disease can lead to heart attacks, right? Myocardial infarction. We'll also talk about cardiomegaly, which we can kind of run into cardiomegaly from many different causes. Again, if you had aortic stenosis, you're certainly going to acquire cardiomegaly eventually. And if I have chronic hypertension, then you're probably going to get cardiomegaly eventually. If you take too many performance enhancing drugs, you will get cardiomegaly. That's why most of the people that seem like super healthy, fit, weightlifters and wrestlers, when they die, they usually die of heart attacks or heart disease or heart failure. So cardiomegaly you can obtain in many different ways. One way could be a pre-existing MI. And you basically just employed more sympathetic innervation for the heart to work harder over time, and it got bigger because of that. But either way, regardless of how we got here, it's always going to lead to something, which is congestive heart failure. And this is what you're going to usually see as kind of the end stage results of a lot of these things, So if I have congenital changes that makes the heart work harder over time, if I have pre-existing heart disease, if I've already had a myocardial infarction before, all these things become much, much more likely. But you can get congestive heart failure without any of these present, right? It can just show up, right? But either way, if I have cardiomegaly, that's certainly going to lead to congestive heart failure. And then we'll even jump into, we'll just kind of say 6-star here. We'll talk about chronic hypertension, even though that's more in the next section, because we'll talk about ways that we can treat some of these things. Right? And a lot of them will share similar treatments because, again, origins are going to be kind of similar too. So that's what we're going to cover overall. And then if we have enough time, so we'll do treatment. TX sometimes is just abbreviation for treatment. And then we will talk about valves and murmurs today. So if you had me in anatomy 2, we talked about something called arms and parts. And it's just a way that we can memorize different types of murmurs. So again, I'll talk about normal valve function. What are valves supposed to do normally? What happens if they're not working appropriately? And there's 2 different ways valves can fail. So we'll talk about that. And then I'll frame a question for you. So if you get questions about murmurs, you'll be able to answer it, because again, it's a very popular application question. It's a popular standardized test question. So I'll throw you a mnemonic that'll help you answer all those questions without you having to think about all the different factors that go into it. So that's useful, and it's good practice, even if you've already seen it before anyway. So we'll definitely do all this stuff today. If we're feeling froggy, we'll do this too today. I'm just gonna see how I feel. If we don't get to this today, we'll throw this in with blood flow and pressure, because blood flow and pressure really isn't that much. So that's the goal. And again, all this stuff that we're going to talk about today, it's in here. So if you're looking through the PowerPoint, here's some of the words I'm going to use in a minute. Certainly, here's just a thing that talks about general problems like myocardial infarction, cardiomegaly, congestive heart failure. And it gives you just, again, it kind of walks you through things like it's a story, like, this is broken and the patient, what's that going to lead to? And it gives a pretty common scenario, but again, it doesn't represent every scenario. It talks about how we diagnose cardiomegaly. Pretty simple diagnosis, really. If it looks too big on an X-ray and it's more than 50% of the thoracic cavity, then it's cardiomegaly. So pretty easy diagnosis, but what does that imply? What does that mean? What's that going to do to affect the patient? Can you fix it? And if you can't fix it, can we at least alleviate some of the symptoms possibly? So we'll talk about that. But again, I've basically just kind of spliced this PowerPoint apart and we pulled out normal. We did a lot of that Tuesday, some of the abnormal we're doing today. But all the information's in there. So first thing we'll talk about, let's just talk about real briefly congenital changes. So congenital changes or congenital defects are basically something that's acquired during the fetal development. It's present at birth. Nothing you can really do about it, unless it's something that's surgically able to be easily fixed. But when you get into the heart, there's a lot of them. Some are going to be way less, common than others. Like you'll maybe one day hear about something called a tetralogy of Fallot, and there's like 4 different components of that, where you have like dextroregurgitation of the heart, and you got all these changes to the vessels. Let's not get into that because, in all honesty, I doubt you're ever going to need that information. But certain simple things that, should be easy to identify, might be present more often than others. Like, for example, interatrial septal defect, right? And even if you've never heard of this thing before, you could at least break the word down if you want it to determine what it is. So that's a useful application right there. A lot of times when I was in school, and Frank asked me this question just the other day. He's like, is there any terminology I should be looking up and learning? And yeah, pretty much all of it. Like it's one of those things where I'm going to try to sprinkle it in future PowerPoints where you start to see in like, what's the medical term that we give for small pupils like meiosis? What's the medical term we give for not sweating? Anhidrosis. We already saw that one when you're dealing with like Horner syndrome, but those words are everywhere. And sometimes the more familiar you are with what words mean and their origin, you can hear a word and maybe figure out what it is before you even read a definition, because a lot of these are Greek and Latin roots, and the words mean something. They're not just random words thrown to describe something. So if I have something called an interatrial septal defect, enter between atria, right? The septum's the wall, it ain't right. So that should be pretty easy to figure out. So if I have 2 pumps in one, right? You have a right-sided pump we call the pulmonic circuit. That's the right half of the heart. You have a systemic circuit. That's the left half of the heart. What's separating these 2 sides from each other? Well, above this line, it's the interatrial septum. Below this line, it's called the interventricular septum. So a septum is just a wall, right? Like we have a nasal septum, and that separates the right half of the nasal cavity from the left half of the nasal cavity. So a septum is just a dividing wall. And if I have an interatrial septal defect, that means the wall is not right? There's a defect in the wall. So if it's between the 2 atria, it's going to be somewhere in here. And it usually originates around this structure called a foramen ovale. There's a anatomical structure that we have when we're still in the womb, because you're not breathing, obviously, fresh air in the womb. That would be kind of weird. So you're using your mom's, oxygenated blood. So when the mom's oxygenated blood comes into the fetal heart, it bypasses the whole right circuit, because we're not going to go to the lungs. The lungs aren't inflated yet. So we have this opening, a foramen, and it's kind of oval shaped in between the 2 atria, and the blood that's coming into this right atrium just immediately bypasses over to the left side, and then we can pump it out to the body, right? So it's normal in the baby, right, before it's born. But once that baby gets born, this thing will start to close off. And there's usually a little flap that'll grow and close down. And so that's essentially what ends up creating the difference between an interatrial septal defect versus a patent foramen ovale. Is, did that flap even form the way it was supposed to, and it just didn't seal, or did it just not form, right? So either way, though, whether it's a patent foramen ovale or an interatrial septal defect, this opening stayed there. So you still will get blood flow going to the lungs, but not all of it. Some of the old blood will actually bypass over here and get into systemic circulation. So if a patient has an interatrial septal defect, the most common thing they're going to present with is fatigue. Right. But the bigger problem, right? So every time they do activity, they're going to get tired, and it's going to be in a young person. So that might rule out congestive heart failure, right? Like there's a lot of things that present with fatigue. Like if somebody has coronary artery disease, every time they start doing more activity, the heart starts to ache and they're probably going to feel fatigued. If they have congestive heart failure, the more activity they do, the more fatigued they get and the more they start coughing and backing up fluid. But this would be fatigue in a young person, right? So usually young people, doesn't really even matter what shape they're in, you know, they don't fatigue very easily. That's the problem with young people, is they're everywhere. So it's not really a problem, but it is if you're trying to, you know, corral them. So if you have this young person that's getting fatigued really easily, there could be a opening in between their atria, and it's allowing some of that deoxygenated blood to spill over into the what should be just oxygenated blood side, and that's going out into systemic circulation. So yeah, that's where the fatigue comes from. But the bigger problem is when you start to get turbulent blood flow, like blood that's just not moving the way it should, that increases your likelihood of clots, right? So if I start to have turbulent blood flow, sometimes you can hear that. It's something that you could probably see with like a Doppler ultrasound, but it's also going to cause more clotting agents to kind of come together, you know, because instead of just going, they start to circle, right? So when you get turbulent blood flow, let's say we have a vessel that has some type of anomaly in it, that's going to create turbulent blood flow because this blood's going to be going through, but as this blood's kind of going around real tightly, it starts to form these little tiny currents, and that starts to cause clotting factors to clump together, and so you can end up forming clots, right? So if I have this little structure right here, you can end up forming a clot, and that clot can get broken off into circulation, and one of the first places it might go is either to the heart itself or to the brain, you know? So no bueno. So that's a problem with interatrial septal defects, right? So you have a basic setup to the heart. If the basic setup's not right, obvious problems. Next congenital problem that I'm going to talk about is, let's again draw our little circle diagram. And let's focus on this left side right here. As you have oxygenated blood coming from the lungs, it's going to enter into the heart through pulmonary veins into the left atrium. From the left atrium, we are going to then pass through a bicuspid or a mitral valve, right? That's an AV valve on the left side. So again, AV, atrioventricular. The AV valve on the left side is your bicuspid or mitral. Right? And then you end up having your left ventricle, which is going to pump into a semilunar valve down here. And this semilunar valve is your aortic valve, which is a type of semilunar valve. All right. And as long as these valves are working appropriately, and we'll come back to this later, that should allow ease of flow in a single direction at least. So if that AV valve's opening the way it should, we should easily get blood coming from the lungs through the pulmonary veins into the left atrium, from the left atrium through the bicuspid or mitral valve into the left ventricle. And hopefully this aortic valve is nice and open when it opens, and it should, as we build up pressure in here, shut this valve so we prevent backflow, open this valve up, and blood should be able to eject out into this aorta, right? And that's the normal flow of things. But let's say there's a problem right here. What if my aorta itself is built too narrow, right? What if the road that's leading out of the major side of the heart is too narrow, where you're always going to have traffic in here? And if you've always got traffic in here, that's going to increase the pressure right there. And when that pressure is always high, that doesn't mean that this is not still applicable. Cardiac output always has to equal metabolic demand. So if I have an aorta that's too narrow, we usually call that aortic stenosis. Stenosis just means too narrow. You can have stenosis of arteries. You can have stenosis of pathways where nerves travel, right? If you have something called spinal stenosis, that means your area where your spinal cord is going in between the vertebrae is too narrow. So stenosis just means narrowing. So if I'm born with aortic stenosis, that's a big problem, because that means you're always going to have to be pumping blood into a much higher pressure vessel. And that means you're going to have to overcome that, because cardiac output still has to equal metabolic demand. So this ventricle is going to have to work harder every beat its entire life, right? That's a big deal. So that's why this ends up being used as a really good like standardized test question, because there's very predictable results of aortic stenosis. If this is high pressure and I'm having to overcome that pressure, that means this has to beat harder. So what's going to happen to that left ventricle over time, if it's going to have to work harder? Well, it's a muscle. It's going to grow. So that's going to eventually lead to cardiomegaly, and that's eventually going to lead to congestive heart failure. Okay. So again, simple concept. If you know what stenosis means, you know what the aorta is, you can pretty much predict what's going to happen. Easy peasy. So those are examples of, if I know normal flow, like where am I going first, second, third, right? Fourth, fifth, sixth, seventh, you don't have to really number it. But if you know normal flow, you can predict what's going to happen if there's a problem anywhere along the line. So what if the problem was right here? You know, you could have a problem with the aortic valve. Maybe you could have a stenotic valve. Well, it's still the same problem. You're still going to have to overcome that, right? But it's something that I'm going to audibly be able to hear with a stethoscope, right? You'll hear a murmur right there. You know, what happens if the mitral valve doesn't close well, right? Maybe you have some type of mitral valve prolapse and blood backs up every time this beats. Well, if blood is being pressurized by that left ventricle in order to overcome normal peripheral resistance, let's say the aorta is normal, but every time my heart tries to build up pressure, the mitral valve leaks. How am I going to get proper blood out, right? So again, when you have problems with just the most basic build of the heart, nothing's going to work right. But you can predict what would happen usually. So if you can't predict yet, you'll be able to predict once we get into congestive heart failure. So easy peasy stuff right there, congenital changes. So no need to keep going with it, because if you can define what the congenital change is, you can usually figure out what's the problem. Next word we're going to talk about is heart disease. Because if you go look up like mortality, morbidity rates of, you know, all the diseases in the known world, and, you know, malaria is up there pretty high, but it's not everywhere. If you look in places that are non-tropical, you know, heart disease and cancers are usually the ones that are number one. And certainly in the United States, heart disease is usually indicated in one of the most common reasons people die. But the word itself is very generic. So yeah, there's a lot of people that are going to die of heart disease, but what does that really mean? So heart disease, by definition, is all encompassing. It can be anything. It could be coronary artery disease. It could be heart attacks, like you're prone to heart attacks because you have some type of congenital defect. It could indicate cardiomegaly, so an enlarged heart. It could indicate congestive heart failure. But certainly this wouldn't be the word I would use if a patient had congestive heart failure. I would just tell the patient they had congestive heart failure. Like I used to have plenty of patients that had congestive heart failure. And so usually I'd tell them, you got right-sided heart failure, or you have left-sided heart failure. I didn't say you had heart disease, right? So you could, and you'd be right. But again, most of the time, when you talk about heart disease, what that typically implies is coronary artery disease. That's what it usually means, which can predispose you to all the rest of these, right? But I guess by book definition, heart disease is any pathology of the heart. But what it usually means if somebody says you have heart disease is it usually means you have some type of blockage in your coronary arteries. So some type of coronary artery disease, right? And there's notes about this in this PowerPoint. There's going to be notes about this in the next PowerPoint next week. The most common reason people get coronary artery disease is usually atherosclerotic plaque buildup of the coronary arteries, right? So atherosclerotic plaque buildup is just a fatty, hard plaque. So when you get into sclerosis, I know that sounds very similar to the word stenosis that we used earlier. It usually means something has hardened, right? If something's sclerotic, it's hardened. So if you've ever heard of the term scleroderma, you know, scleroderma means hard skin, right? So if somebody has scleroderma, you can sometimes see like their fingertips get real tight and it starts to get real shiny skin. It's just become very hard. So if this is atherosclerotic plaque buildup, you know, atherosclerotic plaque buildup is a fatty plaque that builds up in the walls of vessels. And over time, it gets calcified to harden it, right? So this irritation that comes with that causes the vessel to calcify it and harden it. But because there's a plaque in there, it's already narrowing the lumen of the vessel, right? So if I am a coronary artery, my job is to supply blood to the heart muscle itself, right? Coronary arteries are meant to supply blood to the heart muscle itself. If they're becoming more narrow, it's harder to do that, especially under stress, right? So if you stress the person out by making them do exercise, they'll start feeling symptoms if they're not already feeling them already, right? And that's typical of somebody with coronary artery disease. You get them more active, their heart starts to ache, you know, they start building up lactic acid around the heart because you're not getting enough blood to meet metabolic demand. So they're going to start to get ischemia, right? And, you know, part of that is just because of the narrowing of the lumen. So when you're dealing with vessels, the lumen's the open part. Atherosclerotic plaque will narrow that lumen, but it also sets you up for a possible dissection of this vessel. You know, when the vessel hardens, it actually becomes more fragile, brittle. So it's like, you know, glass is a really hard substance, but it's very brittle, right? So when these atherosclerotic plaque builds up in vessels, they can become more fragile. So as blood's pumping through these things, the constant, you know, stretching and snapping back, elastic recoil and stretching and snapping back and stretching and snapping back can cause little tears to form in these things. And if a tear forms and it exposes this fatty plaque to the blood, then a clot's going to form. Or you could simply tear through it and a big clot's going to form. So if you end up getting a big clot formation right there, now you're not getting any blood flow distal to that site. So you're going to have some type of dead tissue, and that's going to be an MI. So again, if I'm a heart, let's just draw something easy. Here is my aorta. Don't worry about pulmonary trunk being in front of that. That's missing. But here's my aorta. Here's my left coronary artery, which mainly supplies the front of the heart. Here's my right coronary artery, which mainly supplies the back of the heart. Let's say we got a, you know, clot that forms right here because we had pre-existing coronary artery disease. Guess what? You die. Okay. So big problem. So a lot of times, you know, where is the coronary artery disease? That makes a big deal. How much? You know, how much blockage is it? Is it 70% blocked? Is it 80% blocked? Is it 90% blocked? Right? And what can we do about it? So if you have coronary artery disease, a lot of times this is going to be monitored, and eventually you're going to have some type of maybe stent or bypass. You know, what can you do about it? You know, what treatment is there possible? You could do a bypass. You could do some type of stent, right? And so the idea is if I have a vessel that is occluded to such a degree that we can't get blood through there anymore, then this tissue is going to become ischemic all the time. There's going to be a lot of ischemia in here because we're not getting any blood flow, right? So every time the patient's active, the chest is going to hurt, right? And so one way that we could possibly treat this is we could just create a bypass that goes around it, right? So maybe they'll take a leg vein and they'll attach that right there, and that will just simply allow blood to avoid this area, right? So that's one thing you could do. Another thing you could do is you could take some type of wire cage and you could insert it using like a little balloon, and the balloon will have that little wire cage wrapped around it. And once the balloon inflates, it'll open that cage up and the cage will kind of lock open and it can force this opening, right, to basically remain there. So that's what a stent could possibly do. So you hear about these all the time. Like sometimes when somebody's having like a triple bypass, that's what they're talking about. They've found, at least 3 vessels that need to be addressed right now. So let's go ahead and bypass some of these things. So that way you can get proper blood flow to the heart, because the heart itself is metabolically demanding and cardiac output always has to equal metabolic demand, right? So if I can't get blood flow there, you can't achieve metabolic demand, the tissue will die. Easy peasy. So what do we call that when the tissue dies? That's our next thing we're going to talk about. So first thing we talked about was some congenital issues. Okay. Second thing we talked about was essentially what is heart disease, but we mainly focused on coronary artery disease. Third thing we're going to talk about is a sequela of coronary artery. I mean, it doesn't have to be, but most commonly it is, which is myocardial infarction. So what is myocardial infarction? That's the same thing as saying a heart attack. And it's based, again, off the idea of ischemia versus infarct, which ischemia is too little blood to meet metabolic demand. Okay. And infarct is too little blood to meet in metabolic demand that is prolonged. And that causes tissue death. So think about tissues that are very metabolically active. Like what type of tissues do you think about when you think about tissues that are metabolically active? Muscle tissue, nervous tissue, right? What's the heart? Heart's a muscle, right? So you could have skeletal muscle infarcts. That's certainly the case. You can definitely have those. You don't hear about those very often, but they occur. But usually if it's the heart muscle, right, that's a very metabolically active tissue. If I can't get enough blood to it because, let's say, pre-existing coronary artery disease, then I'm going to have a heart attack, right? If it's nervous tissue, you might call that a stroke, right? So we might call this an MI or a heart attack. If it's nervous tissue, you might call that a stroke, right? But if I can't get enough blood, so if I can't get enough blood to meet metabolic demand of the tissues, then you will get tissue death, right? So when you're getting into the heart, your heart wall, let's say this part right here, has 3 layers to it. You essentially have an outer layer, which is mostly just serous membranes. So it's actually the innermost part of the pericardial sac. We sometimes might call it visceral pericardium, but it's also the outermost layer of the heart. So we might call it epicardium. So you got that out there. It's a serous membrane. Here, which is the biggest layer, you have the myocardium, right? And the myocardium is the muscle layer, and it's the most metabolically active layer. The innermost layer is endocardium, which usually is just real smooth tissues. So a lot of endothelial tissues, it's going to cover the Purkinje cells. But the most metabolically active layers right here. So if I'm not getting enough blood to the myocardium, so this is called the myocardium, right? This was the epicardium. This was the endocardium, right? If we don't get enough blood to the muscle layer, the part that's beating all the time, the most metabolically active, then we usually call that a myocardial infarction, right? So that is the same thing as saying a heart attack. So myocardial infarction equals heart attack. it's usually due to, again, some type of coronary artery disease. So if I have my aorta right here, and here's my coronary artery, and let's say there's too much of a blockage in here, and the heart's becoming very active, beating, and the blood is not enough to meet metabolic demand for a prolonged period of time, then this tissue will die, right? And let's say it doesn't completely kill you. It's not a massive heart attack, but it's enough of a heart attack to cause some issues temporarily, that's going to create some lasting issues. So, what do you do about heart attacks? How do we recognize what a heart attack is? This is probably the most recognizable event in a person's life, from a clinical or a healthcare standpoint. And not everybody's going to get it, but it's one of those things where almost anybody could recognize just by the signs and symptoms, right? So signs and symptoms of myocardial infarction might be like sweating and pallor, like they get all pale all of a sudden and they start sweating. So that's never good, right? Like if you're all hot and red and sweaty, you look like you just worked out, right? But if you're all pale and sweaty, it's different. So that's no good. Probably have some type of chest pain, which we usually refer to as angina or angina pectoris, right? Doesn't always have to stay in the chest. It could be in the arms. It could be in the shoulder. It could be in the jaw. Right? That's all fair game. And sometimes that's referred to as sclerotogenous pain. It's like a radiating or referred pain, right? Sometimes that's part of a patient intake form. When you ask them, where's the pain? Does it radiate or refer anywhere else? And, chest pain would be a great indicator that it's a heart attack, but sometimes the chest pain will be absent and they just end up having referred pain. Like they have this pain that's just in the arm or just in the jaw or just in the shoulder. But if it was brought upon by activity and it gets better the more they rest, then that's a good indicator. So sweating, pallor, chest pain, they usually have some type of sense, or they'll say something that indicates there's a big deal. So sense of doom is what we sometimes call that. So they'll verbalize something ain't right. Something is wrong. That's what they'll say. They'll say something's wrong. I think I need to go to the hospital. Right? So usually if I ever had patients in the office and they were all of a sudden turning pale and they said something's not right, first thing I do is I just get out the blood pressure cuff, the sphygmometer, see what's going on. And if it's just way off, yeah, heart attack. So as soon as they verbalize that, it's a problem. They will indicate they feel some type of pressure on the chest. So even if they don't feel chest pain, they might indicate that there's pressure on the chest. And it might be verbalized in a way that there's something sitting on my chest. It feels like there's a car parked on my chest. I feel like there's an elephant on my chest, something like that. Activity makes all this worse, because obviously the more active you are, the more active the heart has to be, because cardiac output has to equal metabolic demand. So the heart has to speed up. And if the heart's working harder as a muscle and there's already a problem getting blood to the heart, then the harder the heart works, doesn't mean the blood flow is going to improve all of a sudden, right? The symptoms will be more exacerbated. So activity makes everything worse. So any type of stress will make it worse. So pretty straightforward, pretty easy stuff to kind of identify. So let's say the patient lives through the heart attack. There's certainly ways you could probably diagnose it after the fact, diagnosis wise. So DX sometimes stands for diagnosis. You could look for, say, maybe increased blood products that have to deal with heart cell destruction. So maybe more creatinine, because that's muscle cell component. Creatine phosphate can help us power the phosphorylation of ADP back into ATP when we're spending that for muscles to contract, and creatinine is a byproduct of that. So if this is spilling out into the blood in high quantities, we're assuming that there's some type of maybe muscle issue. Also, it could indicate renal failure, which you would absolutely be going through acute renal failure at the time of a heart attack. So you're going to have increased waste in circulation regardless. But that's going to be high. You're also going to see some high, maybe enzymes like creatine kinase, right? Which is going to be an enzyme that's internal. It's an internal enzyme that helps to use creatine phosphate, right? So creatine kinase or creatine phosphokinase, CPK, you're going to probably have high troponin in the blood as well. And that, again, is an internal component, right? So why would troponin be outside of a cell in the blood? There's no reason for it, right? It's something that we find inside of cells, inside of muscle cells. So if I start to see high creatinine plus, high creatine kinase plus, high troponin, that means cells, muscle cells are being destroyed. So if you had chest pain or the patient complained of chest pain and these are all elevated, then absolutely, yeah, they had a heart attack for sure. No doubt about it. But again, what are some possible sequelae? So here's a word that I'm throwing at you. A sequel, right, is something that follows up. So sequelae are things that we can predict would follow certain events. Doesn't always have to be this way. Again, we certainly don't have to have pre-existing heart attack to get congestive heart failure, but it certainly increases the likelihood. We don't have to have pre-existing coronary artery disease to have a heart attack. Some people just go through what's called vasospasms, right? And they're just completely out of the blue. There's just a lot of stress. And all of a sudden that stress just culminated into some type of vasospasm and the vessels just went zoop like that. And that was it. So again, things don't have to always follow a certain sequence, but when we can predict that they most likely would show up if something's present, we can call that a sequela, right? Sequela is like something that's a predictable outcome that follows a certain event or presence of something. So let's see, sequela of a myocardial infarction could be cardiomegaly. And again, this is certainly not the only reason we get cardiomegaly, and it's probably not even top 3 of why we get cardiomegaly. The most likely reason we're probably going to get cardiomegaly is chronic hypertension, right? And so I would definitely put that up there. Another reason we're probably going to get cardiomegaly is just because you're too big, right? And your heart's having to overcome a lot of peripheral resistance to get blood out to a bigger body, right? But let's say I had pre-existing coronary artery disease and that led to a heart attack, right? Could I reasonably predict that over time that patient's also going to suffer from cardiomegaly? Absolutely. Because when you do have a myocardial infarction, this is how I describe it to students. Let's say pre-heart attack, your heart was strong, right? These are muscles. Okay. Pre-heart attack, your heart was strong, right? Muscles. Okay. And your heart was adequate between that tug of war between your blood flow and your metabolic demand. So here's your heart. Here is the body. And there's a constant tug of war going on. So this is tug of war. Don't they just call it tug o war? I think it's just called tug o war. Tug of war, whatever it's called. Here's the pit in the middle that you get to fall into. I guess we don't get to do that anymore. That would have been a long time ago that they allowed pits. But there's a constant tug of war between the heart and the body, right? It's cardiac output equals metabolic demand, right? So if this is the heart and this is the body, pre-heart attack, your heart was strong. It had the capacity to be able to adequately meet that metabolic demand. But post-heart attack, right, not so strong anymore. Something in the heart has broken, right? So one of these guys is now missing. But that doesn't change the fact that cardiac output still has to equal metabolic demand. And after the heart attack, the body really hasn't changed, because if it's day 1 and your heart was normal, and then day 2, you had a heart attack last night, the body hasn't changed in composition overnight. It's still the same height. It's still the same weight. It's still got the same issues that it had before, right? So body's still going to be the same, but the heart has certainly changed permanently, right? Because that tissue is now maybe turning into fibrotic tissue. It's not viable muscle tissue anymore. So post-heart attack, you've lost one of your guys in the tug of war match. So guess what happens? These two guys have to work harder forever, for the rest of their life, right? So usually when a person has a myocardial infarction, you get what's called 2 essential effects, right? So you have decreased cardiac output, which is, so you'll have a decrease in cardiac output, and that's going to increase backup of blood in veins, right? Those are the 2 essential effects of a heart attack. You'll have a decreased cardiac output because your heart's been damaged, weakened. It's going to take a little bit of time to heal. It just lost one of its guys. And so blood starts to back up into the veins, right? And eventually we're going to have to fix that, because once blood starts to back up into the veins, that's going to increase baroreceptor input, right, from the venous side to the medulla. And the medulla is going to respond by sending more stimulatory signals to the heart through sympathetic nervous system, right? It's not a direct signal, but it will be. Medulla says, all right, spinal cord, I need you to start sending more sympathetic innervation to the heart permanently, right? It's a permanent change, right? Because we need to get that blood moving forward so we can empty those veins that are, not empty them, but we can allow blood to start flowing better so there's no more backup, right? So again, here's an input, here's an output, right? So this is permanent. So when I employ sympathetic innervation, so increased sympathetic tone to the heart is going to increase heart action. And part of heart action, it could be heart rate. In this case, it's probably going to be heart contractility, because again, part of your heart died, but whatever's left has to work harder, So part of that is increase in heart contractility. That's the actual vigorousness of how that heart is working. So again, the surrounding tissues before could work more like this, but now because there's not much of them left, they're working more like this. They're like, So it's a heart, right? And a heart is mostly a hollow muscular sac. So if I'm increasing heart contractility, that's increasing heart muscle activity, and that's going to increase heart muscle size, right? So over time, your heart's going to change. Over time, your heart's going to change. Okay? Which can then lead us to cardiomegaly. Okay? Certainly not the only way we can get cardiomegaly. Again, it's not even probably top 3 reasons we get cardiomegaly, but I just want you to follow the logic here. So once you see a patient with an MI, it's not like that's the last you're going to see them. They're going to have to change their ways, right? Because this is coming. And you need to take stress off the heart, because you can't fix heart attack, right? I can't regrow, well, maybe one day you can. But as of right now, we can't regrow fibrotic heart tissue. Once it's damaged, it's damaged. So it's simply going to have to work harder. But what are factors that maybe I could work on in the body that gives the heart less strain? Maybe we could decrease peripheral resistance. And we'll talk about that more next week when we get into blood flow and pressure. Like I have to pressurize the blood enough to overcome what's called peripheral resistance. And peripheral resistance can be altered by tension, like how tense are the vessels, how much atherosclerotic plaque is there, how long are the vessels. So if I'm a bigger person, the vessels have longer to travel, right? You know, how stressed am I all the time? Am I constantly in a higher vessel tone because of the sympathetic nervous system? So there's a lot of things that we can work on. But over time, if you had a heart attack, most likely you're going to eventually get some form of cardiomegaly. And cardiomegaly just means an enlarged heart. So let's do cardiomegaly real fast, then we'll take a break. And then we'll come back and we'll work on congestive heart failure. And then we'll talk about treatments. Throw in, again, chronic hypertension, because that goes along with treatments. But cardiomegaly just means an enlarged heart. By definition, it's a heart that takes up more than 50% of the thoracic cavity on an X-ray. So easy to diagnose. And a lot of times it's diagnosed when you're looking for something else. They're like, yes, you have pneumonia. By the way, did you know you also had cardiomegaly? It's amazing how much change occurs in the body before sometimes you see symptoms. A lot of times it's too late, especially cancer, right? That's why cancer is so bad, because you don't have symptoms of cancer until it's already too late. So with cardiomegaly, it just means an enlarged heart. But before we can talk about why an enlarged heart is such a bad thing, let's talk about normal again. So if this is a normal heart, a normal heart with its normal size, right? If they ever ask you what is the size of a normal heart, it's about the size of a relaxed fist, right? So my fist should be somewhat proportionate to my body, right? Because it's my hand, you know, attached to my body. And if I loosely clench that, that should be about the size of my heart. So it's not enormous, you know, mine's much greater than this because of the endless love that I have for everyone, right? But still, this is a normal person's heart. And inside that heart, we have to have a couple of properties that makes the heart work well. So again, let's just focus on left ventricle, because that's where most common changes are going to occur. In a normal left ventricle, right, I have to have two attributes that make it work. I have to have good chamber size, because I have to be able to fill it with enough blood, right? Because when I contract, you want to generate stroke volume, and that's how much blood's leaving. So if I can't get enough blood in there, how can you have a lot of blood leaving? So you have to have good chamber size, because you have to be able to hold good volume, and you have to have good contractile properties. I have to be able to squeeze that chamber adequately. So you have to have nice, thick, but not too thick muscles, because they still need to be distensible if I want to preload them, but they still have to be able to contract, and you have to have good chamber size. So that's normal heart, okay? But with cardiomegaly, it can go in one of two directions. Either way, cardiomegaly is an enlarged heart. But you can have an enlarged heart that looks like this. And again, I'm just focusing on left ventricle. You know, it doesn't always have to be left ventricle. This is just the more common side. So you could have a heart that's enlarged like this. We sometimes call that dilatation or dilate it. I like dilate it because that's what normal people would say. Right? But this is what we might refer to. This is cardiomegaly for sure, right? That's cardiomegaly. That's one type. And it's called dilated or dilated cardiomyopathy. So disease, heart muscle, dilated, overly dilated heart muscle. So it's a disease of overly dilated heart muscle. So what attributes does this heart have? What attributes does it not have? So certainly got good chamber size, check, right? How about good contractile property? Negative, right? So this heart sucks, right? This heart sucks. Next one. That was easy determination, wasn't it? So next one, still cardiomegaly. Let's look what has happened with the heart. This heart has been overly worked. It's been pumping real hard because it's having to overcome some type of either greater resistance. Maybe the resistance is the same, but the heart itself was injured. Whatever, this heart's been working real hard and it got too thick. So again, it's an enlarged heart, but it has enlarged by thickening, like thickening. So not only is it thickening outward, it's thickening inward, right? So the heart's enlarged, but this wall itself has become too thick, too overly muscular, right? So this is called hypertrophic. You know, it has grown too big. Heart muscle disease, cardiomyopathy. Disease, heart muscle, grown too big. Okay. So what property do we have in this one? Well, definitely got good contractile properties, right? This guy's flexing his muscles on the beach, but chamber size is gone and he can't be preloaded very well because this thing will not relax and you cannot stretch out a heart that's too rigid, right? So that's no bueno. So this one also sucks. So normal, good, abnormal, this one sucks, abnormal, this one also sucks. Okay. So once these changes have occurred, what can I do about it? Well, maybe make the dilated one beat harder. Maybe make the hypertrophic one relax better. So again, that's where the medications might come. But again, you have to treat the underlying disease of why did it get this way to begin with. And why it becomes enlarged one way versus the other, they don't know, right? I mean, obviously, this one has gotten too thick because it's just been working too hard, right? It's a muscle, it's grown, it's hypertrophy, just like other muscles hypertrophy when you work them too hard. But in some people, we end up preloading and distending the heart out so it has more snapback, and then you preload it more and it distends out and it has more snapback, and then you preload it and it distends out and you have more snapback. But over time, it got stretched and stretched and stretched. So that was a good way to increase stroke volume, because if I increase preload, I increase stroke volume. It's Frank Starling law or Frank Starling mechanism, but it got overly stretched out. So maybe with some type of dilated cardiomyopathy, you might want to add inotropes, some type of medicine that's going to stimulate that heart muscle to beat harder. So even though it's all stretched out, let's just make it work better. Right. And then if I have some type of hypertrophic cardiomyopathy, I need this thing to relax. So maybe some type of, let's just say inhibitory, beta blocker, or maybe even a calcium channel blocker, okay? But we wanna tell this thing, relax a little bit, big guy. You need to take it easy. And beta blocker does two things for me. It's going to relax this muscle tissue a little bit. Plus, it's also going to increase my diastolic refilling time because it's going to go slower, right? Because cardiac output equals stroke volume times heart rate. Norepinephrine can increase both of these, not so much stroke volume as it does heart rate. But if you got the presence of both norepinephrine and epinephrine, beta blocker will work on both. So it's going to decrease essentially how fast the heart's going, right? How vigorously it contracts, but at the same time, it's also going to increase how much blood can fit into it because it's going to decrease this muscle tension, right? So, anywho, that's thought. So next thing we're going to do, when you have cardiomegaly, you have to have congestive heart failure, right? There's no ifs, ands, or buts about it. If you have cardiomegaly, you're automatically diagnosed with congestive heart failure. So how we describe congestive heart failure is going to be the trick to understanding it. So we'll do that in a few minutes. So we'll take a quick break here. I'll pause the recording. Right. So, welcome back. Just had a little break there, refilling our coffee and emptying our dogs. That's what I was doing. We just got done talking about cardiomegaly. Some of the possible causes of cardiomegaly could be things like maybe chronic hypertension. If I'm constantly having to overcome a higher what's called peripheral resistance, which is basically the amount of force that the body's pushing back against the heart. If that's always high, because I'm constantly stressed or just too large a person, or there's a multifactorial cause for the chronic hypertension, then the heart's still got to overcome that, because again, cardiac output always has to equal metabolic demand, no excuses, right? But I couldn't have cardiomegaly because I had some type of pre-existing heart problem. Maybe there was aortic stenosis, maybe it was a congenital defect and your heart was constantly trying to overcome that pressure right as blood was leaving the aortic valve into the aorta, and the aorta was simply too narrow. You can see the consequences of that. Maybe I had a heart attack and the remaining parts of the heart were overworked, right? Just like probably most of you feel. And if you're overworked all the time, you're eventually going to wear out. But before that, the heart's going to change. It's going to get thicker and more rigid, or it's going to get stretched out to its limits. So whenever you get cardiomegaly, it's never good, right? The heart has made alterations, and for a time it worked. It's not like the body's just doing this randomly for no benefit. At the beginning, cardiomegaly is useful, right? When it was getting bigger and stronger, it was working better at that time, but we eventually got to a breaking point. And when it was being overly distended, for the first part of it, like a fresh rubber band, you can stretch it out pretty far and it'll still snap back, and you can stretch it out pretty far and it'll still snap back, and it is more efficient, right? So the heart was going through changes to make the heart work better for the time being, but the body didn't always live 120 years. Sometimes the lifespan of a human was only 30 or 40 or 50 years. So as we're approaching, the average lifespan being 80, 81 years, then of course we see these things more often now, because what was a good change for a short amount of time now has to last longer, and it's just not holding up. So we see the effects of that. But again, at first, cardiomegaly was okay, because before we got to the breaking point, it was helping the heart overcome whatever challenges that it had. But eventually we got to a point to where it became less efficient. You got bigger and stronger, but too big and too strong, or you were stretched out a little bit so you could have better, snap back, recoil, but you got stretched out too many times. So regardless of how you got cardiomegaly, there's consequences to that once you have cardiomegaly. And one of those big consequences is congestive heart failure. Okay? And it's a given. When you do have diagnosable cardiomegaly, it's greater than 50% of the shadow on a thoracic x-ray, then that is at the point where you're going to have congestive heart failure. But a lot of other things are going to happen too. When you have cardiomegaly, it might mess up how your valves work. So you'll probably maybe have a murmur or two. When the heart changes shape, the valves aren't necessarily able to accommodate that very well. Sometimes when you have cardiomegaly, you're also going to get dysrhythmias or arrhythmias, because you're making it harder for signals to transfer through a thicker wall, right? So, these things will show up on EKGs and stuff too. But it also might create a arrhythmia, the cause of the cardiomegaly. But, maybe not for certain. But one thing that certainly takes place when a person has cardiomegaly is they certainly will have congestive heart failure. So let's look at congestive heart failure. Let's just define it first. Congestive heart failure, for us, I'm not talking about like a definition on Google, is a problem with forward flow. And this is how some books will describe it, but most of the time it's going to talk about some type of lung congestion and symptoms. But overall, what's the issue? with congestive heart failure, you're having some type of problem with forward flow. And maybe it's the heart's fault, maybe not, right? But you're failing to get blood adequately to its destinations. That's the problem. But all the signs and symptoms are going to be due to the backup, right? So how we're able to diagnose congestive heart failure is coming from the backup, not from the problems with forward flow necessarily, okay? So you'll see what I mean as we go through it. But with congestive heart failure, regardless of which type it is, there's a problem with forward flow, right? So let's look at our examples here. So here's our circle diagram, which we can use for basically anything and everything. That's why we use it. Congestive heart failure can be subdivided into two types. You can have left-sided heart failure, and you can have right-sided heart failure, okay? Most common of the two is left-sided heart failure. For obvious reasons, left side has the harder job. The left side is the bigger of the two sides. So which one is most likely to fail? The bigger one that works harder. So most common form of heart failure is left-sided heart failure. So again, this all falls under a big category called congestive heart failure. The term congestion is literally limited to left-sided heart failure. If you don't have left-sided heart failure, you're not necessarily going to have the congestion where the word came from. I mean, you will congest venous flow for sure, but it's not the same as where the original word came from. But congestive heart failure actually referred to the pulmonary congestion that you get due to left-sided heart failure. So CHF or congestive heart failure, there's subcategories to that. You can have left-sided heart failure, you can have right-sided heart failure, you can have both left and right-sided heart failure, or you can have right-sided heart failure in the absence of left-sided heart failure. So left-sided heart failure is the most common, so we'll talk about that one first. Again, if we are dealing with heart failure, the problem is with forward flow. So the problem is getting blood out, okay? So what are some different reasons we might have difficulty getting blood from a left ventricle out to systemic circulation? Maybe the system is fighting back. And again, there's too much peripheral resistance, right? So chronic hypertension could be a reason we're having left-sided heart failure, right? Maybe, again, you have aortic stenosis and the aorta itself is too hard to pump into. Maybe you have atherosclerotic plaque buildup in the aorta in some of the major vessels of the body. Again, that's going to increase peripheral resistance. Maybe you had a heart attack and the heart, again, changed size and shape to overcome its problems then, but it has caused the heart itself to become less efficient. So maybe outside is normal, but the heart is less efficient. And so we're having difficulty getting blood out. So again, there's many reasons why you could have congestive heart failure. There's many reasons that could explain the origin of left-sided heart failure. But the problem is we're not getting enough blood out. So all the signs and symptoms are going to come from the backup of that blood. So since we already know how blood normally flows through a heart, where is blood going to back up to when you have left-sided heart failure? Well, where does it come from to enter into the left side? It comes from the lungs, right? So you're going to start to get a lot of blood backing up into these pulmonary veins. And as the blood backs up into those pulmonary veins, we'll talk about this more next week, it's going to congest that area. It's going to start to create a bigger gap between your alveoli and your pulmonary capillaries. And that fluid that starts to build up in that gap, that fluid exudate that builds up in that gap between the alveoli and the capillaries is going to start to enter into the alveoli, the air sacs, which should only have air in them, right? And you're going to start to feel very congested and you're going to feel like you have to cough up that fluid. So the main sign and symptom that we see with left-sided heart failure, which is the most common type, is every time you become active, you have cough and sputum production. And the sputum can be frothy, it can be whitish, it could be pinkish, could have some tinged blood in it. But every time you're active, you have a productive cough. You get rid of the activity, it disappears. Okay. But the main sign and symptom of left-sided heart failure is cough and sputum production. That means we're starting to back up fluid into the lungs when the heart becomes more active. Right? Ultimately, yes, you'll drown from that. You'll eventually drown from that. But some other things that the patient themselves might notice is they're going to have, chronic fatigue all the time. And one of the reasons that they get so fatigued is, yes, they're getting less blood out to the body than what they want to. But at the same time, that blood is less oxygenated, because if you start to increase the gap between the capillaries and the alveoli, which we are with fluid, and some of that fluid's actually taking up space in alveoli, diffusion doesn't work as good. So they're going to feel fatigue all the time. But they're also probably going to carry some type of handkerchief with them all the time too, because every time they are more active, they're going to start coughing up fluid, right? So cough and sputum production gives away left-sided heart failure. Easy diagnosis. You don't need an X-ray to diagnose left-sided heart failure. Just tell them to walk, from one side of the room to the other. Easy diagnosis. Okay. So if a person has left-sided heart failure, which is the most common type, right, then they will eventually also get right-sided heart failure. Okay. So let's do right-sided heart failure. So let's say I had pre-existing left-sided heart failure. And because we were having difficulty getting blood out to systemic circulation, remember with congestive heart failure, the problem is getting blood to the destinations. The problem's with forward flow. But all your signs and symptoms are due to the backup, right? Again, that's why we draw our circle diagram, so it's easy to see where the backup goes. So with left-sided heart failure, my backup goes to the lungs. That's what gave us the cough and sputum production. But now your lungs themselves have become congested. Okay. It's like traffic, right? Congestion is like saying traffic. There's too much traffic. So too much stuff in a place that's not meant to hold that much stuff. Kind of like I-85. So if the lungs themselves have already become congested, guess what that's going to do? That's going to cause the right side of the heart, which really isn't that big and that strong to begin with, to start to back up. So now we're going to have a problem here, and that's going to start pushing blood back this way, right? Which is going to lead to right side heart failure, okay? Which is going to make the fatigue way worse, right? Because now we're not even getting enough blood into the lungs. But you can see how this is like a very cyclical type of thing, It's a domino effect. Once one domino falls, they all kind of fall much easier. But now when you have right-sided heart failure, which the most common cause of right-sided heart failure is pre-existing left-sided heart failure. It doesn't have to be. You can have right-sided heart failure in the absence of left-sided heart failure due to pulmonary hypertension, right? Which can be caused by other things. But if you have right-sided heart failure, what are all the signs and symptoms? They are usually all backup of fluid in a venous system related, right? So usually some type of swelling or edema related. And when you're wondering, well, where is that swelling and edema at? Well, where does blood come from that's coming into the right side of the heart? Everywhere. It's coming from everywhere. It's coming from the whole body, right? So we might see signs in the jugular veins that lead into the superior vena cava. So you might start to see something like, so signs and symptoms of right-sided heart failure. You might have jugular venous distension, or JVD, right? So if somebody's neck veins are sticking out all the time, they have right-sided heart failure. They might look as healthy as they can be. They might look like they are like a Greek god, but if they got those neck veins sticking out all the time, even if they're just barely talking, they got JVD, they have some type of heart condition. It's an easy diagnosis, even though sometimes you'll be like, I don't know, maybe they just have really lumpy veins. No, they probably have right-sided heart failure. It's real bad when they get the big V on their forehead too. Like you got forehead veins sticking out just because you're talking. Talking shouldn't be that strenuous. that's a problem. All right, so JBD is when the neck veins stick out. Again, you can see some of these things sometimes. Let me share a screen with you real quick. Let's see what the Google machine says. And JVD patient supine. Let's see. There we go. So a lot of times you can see it when they lay back. You know, if you can see it all the time when they're sitting pretty upright, it's pretty advanced. But a lot of times it doesn't get so noticeable until they lean back, right? So the examiner's table usually has a reclining top, and it's got a little protractor on it. So you can actually even see what level does JVD show up, right? And I'll explain how it works in just a minute. But anywho, that's one of the things you start to notice. So jugular venous distension, they can also have a jugular reflex, which I'll show you how that works in just a minute. I think I showed my class, because this was one of the things that I demonstrated to one of my Amish patients. I used to live in Indiana for like 12 years. I don't suggest that anybody ever does that. If you have a choice, stay where you're at, even if you think it's terrible. But some of my Amish patients, I'd have to do house calls. So I'd have to go out to their house, and I can't remember why the husband called me. He's like, can you come and look at my wife? I don't think he really even gave an explanation. And I was like, yeah, we can do it today, like 4:15, blah, 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 blah. And he was telling me where he lived, and I'm like, all right, I know where that is. And I drove out there and pulled in, walked to the door, knocked on the door. He came and answered, and wife wasn't in the living room right when I got there. He's like, I think she's in the bathroom. She'll be out in just a second. But immediately I knew what she had, because I had seen that the entire recliner in the front living room had become like, I don't know, ground zero for her life at that time. You know, you could tell everything that she ever needed in life was now situated around that recliner. There were pillows and blankets, and she had, I noticed remote controls, and I was like, it's like, you're Amish. What are those going to? You know what I mean? But, you know, knitting material, drinks, you could see drink bottles that were empty, food, containers, snacks, and you know, so you could tell she did not leave that recliner very often, and you could tell she slept in it at night. And so I'm like, I think I know what's wrong with you. And so the first thing I said is, you know, are you getting tired and fatigued and your feet swelling and stuff like that? And she's like, yeah. And I'm like, well, you most likely have right-sided heart failure. And I was like, there's really nothing we need to do about it. I was like, don't worry about it. You've had it for a while. I can tell, you know, just by the way she had her living room set up. And then the husband's like, no. He's like, I talked to some herbologist or something like that. And I was like, okay. And he's like, no, it's definitely not this and definitely not that. And I was like, all right. And so I was like, well, let me demonstrate something to you just to show you that I know a little bit more than the herbologist does. And I did something called a jugular reflex on her. So let me see if we can do this. Let me see if we have a demonstration so I don't have to do it in words. See if there's a GIF for it. Well, good enough picture. So what I did was I just took a clenched fist, and normally you'll just take a fist and you will compress into their rib cage right where you suspect their liver is. So you can kind of see it in this picture right here. You can kind of see it in that previous picture right there. She was sitting up in the recliner where that's her, again, ground zero. So basically all I did was I just took my fist like this and I put it under her rib cage on that side, and I just pressed in real lightly. And then I told him, watch her neck. I said, just watch her neck. And soon as I had pushed my fist in, no more than like this, I just pushed it in like this, and her jugular vein went like this, went, and it was, I kid you not, it was the size of a softball. It was like bigger than this mouse. I was like, that's not good. You know, and I think to myself, I said, no, I think out loud, I was like, ooh, you know, which you're not supposed to do that when you're a physician. You're not supposed to go, ooh. You're supposed to go, huh. It's literally something you're taught in school called doctor speak. So you don't freak out the patient. So that way you look more professional too. So I went, ooh, but still, I was demonstrating to him a jugular reflex that essentially what had happened. Let's talk about why this happens. If I am a patient, person, doesn't, you don't have to be a patient to be a person necessarily. Here's my heart, give or take centimeter or two. Here is your superior vena cava leading into the heart. So superior vena cava drains head, neck, and arms. Something similar to that. That's actually not a bad diagram of that. So you got jugular veins coming down from the head and neck. You have subclavian veins that are like consolidation of like cephalic and basilic veins in the arms and stuff like that. And those all drain downward. And normally these have right of way, because if I'm upright, gravity helps these things drain better. So that's why if you see a patient kind of leaning back and all of a sudden blood's backing up into that jugular vein, it kind of explains why, because when I lose that assist that gravity gives me, it's showing me that the heart's backing up into the venous system. And again, why is the heart backing up? Because I have some type of problem with forward flow, right? And if that happens to be on the right side of the heart, right, where am I going to back up into? Well, I'm going to back up into the venous return of the body, which would include superior vena cava, which is right here, which means my jugular veins are going to get backed up, right? And normally, if you see JVD, it's on a patient that's leaning back. But let's say this patient's sitting up and I want to show JVD anyway, or they could be leaning down like you're seeing in some of those pictures. Like she was sitting up. So that's why I used my fist, and I was going to push in quite a bit harder than what I did. I didn't need to though, right? But as soon as I put my fist in her liver, essentially, what had happened is I started forcing a lot of blood back to the heart through the inferior vena cava, right? Because the liver is one of the big drainage areas of the entire abdomen. Like all the blood in the abdomen is draining through that liver first, right? And so it's called the hepatic portal. So all your digestive system, which is a lot of organs, believe it or not, go through that hepatic portal. And your liver holds a lot of excess blood. So when I pressed that blood in the liver, then the inferior vena cava had right of way. Now superior vena cava got backed up, and so you saw the blood start to back up in her jugular vein. So we call that a jugular reflex, right? It's a really good, easy demonstration to show that somebody has right-sided heart failure, right? So it's showing the blood back up in that superior vena cava. But again, this isn't something the patient's going to notice. There's a difference between signs and symptoms. Right? Signs is something you see. Symptoms is something the patient notices and feels. So the patient's going to notice the swelling of the feet, right? The swelling of the ankles, right? Swelling of the hands and the wrists maybe. So they're noticing with their right-sided heart failure, all the edema, and it's a certain type of edema called pitting edema, right? So they're noticing all the edema, which usually starts most distally first. So when a lot of that blood gets backed up into the venous side of circulation, veins kind of start most distally and they work their way back. So they start to swell like in the lower extremities first with the feet, right? Then the ankles, and then the calves, and maybe fingers and hands and wrists. So when they're taking their socks off, the pit stays, right? So it looks like a sausage. Right? When they take that sock off, the pit stays. Or if you just take your finger and you poke it in the foot and you pull your finger out, the pit stays. Or when they take the watch off, the band mark stays. Or they take the ring off, the finger, the little, the little pit stays, right? So pitting edema is pretty easy to diagnose. And it looks like a pretty firm type of edema, but it has a little bit of a give to it, right? Different from edema from injury. That's more firm, right? And it doesn't pit. It bounces back. So this is one of the main signs and symptoms of the right-sided heart failure. But the reason I diagnosed there wasn't any of that. It wasn't the JVD. It wasn't the edema. I hadn't seen her feet yet. It was because she had paroxysmal nocturnal dyspnea And she didn't have to tell me that. I could tell because she slept in the recliner, right? And the only reason you're going to sleep in the recliner if you're an Amish woman is because you're either mad at your husband because he wants too many babies, or you can't sleep laying down flat at night, right? So the paroxysmal nocturnal dyspnea means when they lay down at night, they have difficulty breathing, kind of comes and goes, because when they're flat on their back, all this blood flow from the lower extremity starts to go back to the heart, and it congests a heart that's already congested, right? It's sending more traffic to a heart that's already backed up, right? That's like opening the floodgates to, I-85 from like Gastonia and Charlotte when there's already a traffic jam or a wreck. It's sending more vehicles in, so it's only going to exacerbate the symptoms. So when she sits up at night to sleep, the blood drops back down into the lower body better because she's more elevated, and it takes some of that pressure off the heart. So that's what we were noticing is the paroxysmal nocturnal dyspnea. So you can usually tell that in a patient when they say they have to sit up at night to sleep, or they have to sleep in a recliner. So again, it's pretty easy to diagnose right-sided heart failure. There's a lot of signs and symptoms that the patient can present with. So again, with congestive heart failure, right, most common type is left-sided heart failure, where we're having difficulty getting blood out into systemic circulation for whatever reason. Could be a heart issue where the heart is going against normal resistance and it's just not good enough. It could be a resistance issue where the body's just too big or too hard or too resistive of blood flow. So the heart has to compensate for that over time. And you get changes, and the heart just eventually breaks, and it's not able to overcome that peripheral resistance anymore. And so you start to get a backup. So again, with congestive heart failure, the problem is getting blood out, but all the signs and symptoms come from the backup. So with left-sided heart failure, my signs and symptoms are cough and sputum production early on. But eventually, if it's left, then all left-sided heart failure will eventually become right-sided heart failure, and you'll get all the signs and symptoms. You'll have cough and sputum production plus all the signs and symptoms of right-sided heart failure, which most of those have to do with fluid backup. So they're getting edema, JBD, right? The pitting edema, of course, JBD, paroxysmal nocturnal dyspnea. I'm not going to put that on there. We can put dyspnea, difficulty breathing, right? Fatigue is going to be with all these things. And the most common cause, again, of right-sided heart failure is pre-existing left-sided heart failure. But you can have right-sided heart failure, so right-sided heart failure in the absence of left-sided heart failure is usually called cor pulmonale. So right-sided heart failure in the absence of left-sided heart failure, we call cor pulmonale. It's basically like saying the problem's centered in the lungs, right? So if you have cor pulmonale, again, which is right-sided heart failure without left-sided heart failure, it's usually due to some type of pulmonary hypertension, which could come from some type of restrictive lung disease, which could come from things like sarcoidosis. It could come from cystic fibrosis. It could come from diffuse idiopathic skeletal hyperostosis. We'll talk about those when we get into respiratory system and gas exchange. But it's basically making the lungs harder to move because they either have some type of infiltrates, or the surrounding area that holds the lungs is more stiff, right? So restricting their movement, which creates more pressure. So, but again, most common cause of right-sided heart failure is pre-existing left-sided heart failure. So with left-sided heart failure, you always have to have cough and sputum production, but you'll eventually usually have cough and sputum production plus swelling and edema, because you'll usually get that. But if you have all the signs of right-sided heart failure without cough and sputum production, then it's probably coming from one of these. So again, it's not hard to diagnose. I never really required any extra test to diagnose heart failure. So what's the treatment? treatment. So treatment usually is symptomatic at best. Most of the time when you're trying to treat congestive heart failure, you have to remove whatever the causative mechanism was, which is generally not that easy, right? But when you're treating for hypertension to congestive heart failure, again, maybe the congestive heart failure came from cardiomegaly and your heart was too big and saggy, right? That was what I was talking to you about before, where inotropes might be useful. So if I have a big saggy bag heart, which we sometimes again see that with dilated cardiomyopathy, right? Like if this is, let's say this is normal heart, right? And here's congestive heart failure where you have cardiomegaly present. If my left ventricle has become too dilated or dilatated, I usually refer to that as like the big saggy bag heart. It's big saggy bag, right? Holds lots of fluid, but it's not strong enough. So you need to make that work harder. So that's, again, inotrope. Inotropy is like the contractile properties of a heart. So inotropes can help make that heart fire better. But if I have this type of congestive heart failure where it's become too thick, this is the thick, rigid wall type of congestive heart failure, then you need this to relax. So again, maybe beta blockers would be useful. And at the same time, not only will that help it relax, it's also going to give us more refilling time because it slows down the heart rate, right? So again, sympathetic innervation can increase both heart rate and stroke volume. And we determined that a long time ago before we even got into the heart, right? Sympathetic versus parasympathetic, norepinephrine and epinephrine, or adrenaline, acetylcholine, right? And when we're dealing with changes we see in the body with sympathetic innervation, think increased heart rate, increased heart contractility, increased respiration rates, increased blood pressure, or we might have said vasoconstriction, right? We've already mentioned that before. So if I block sympathetic innervation with something called beta blockers, because sympathetics, in order to apply its effects to a target tissue, has to be picked up by a receptor. And sympathetic receptors are called adrenergic receptors, and there's two types, alpha and beta. So if I'm a beta blocker, that means I'm blocking beta adrenergic receptors, so they can't receive norepinephrine or epinephrine. So the receptor site that's supposed to be receiving, say, norepinephrine or epinephrine is blocked. The beta blocker. So that's going to decrease heart rate, decrease heart contractility. So it's going to allow the muscle to relax a little bit, and it's going to slow down the heartbeat. And if my heartbeat is slower, that means I have more refilling time, right? Because there's more time for blood to get in there between beats. So that'll help. Right? Let's see, what else do we have on there? Other things, like let's say that we are dealing with congestive heart failure, and maybe we got there because the vessels are too tight. So that's dealing with hypertension. Maybe we had a pre-existing heart attack, and part of the heart problem is you have coronary artery disease. Well, you can relax vessels, right, with nitrates. So I think that's going to be effective over here as well. But a lot of times when you're dealing with backup of blood, right, with congestive heart failure, you're getting a backup of blood. There was something that we talked about in anatomy too, that blood pressure has a lot of things that contribute to it. And one of the main contributing factors to blood pressure was blood volume. And I always star the crap out of that. Like star. The most directly proportionate thing to blood pressure is blood volume. And other things that can contribute to blood pressure could be things like, vessel tone. We didn't call it that at the time, but it could be heart action, could be vessel tone. And so heart action obviously contributes to blood pressure as well, because that's what's generating it to begin with, but you have to have a volume to squeeze on. So if I have too high a volume, you're going to have too high a pressure, right? So if I'm trying to treat hypertension, then maybe treat this or this, right? So if I want to decrease fluid volume, then diuretics might be useful. Lasix might be useful. You could go as far as to use a renin-angiotensin-aldosterone blocker that we call an ACE inhibitor, because that will block the renin-angiotensin-aldosterone system from making it to the end. And by using an ACE inhibitor, I'm going to remove what stimulates aldosterone and antidiuretic hormone. So we will lose, with an ACE inhibitor, we will get rid of fluid volume. And we're also going to remove two very strong vasoconstrictors. So that can help us decrease vessel tone as well. So if I want to decrease fluid volume and vessel tone, ACE inhibitor can do both, right? Because we're going to decrease fluid volume by blocking the effects of aldosterone, which reabsorbs sodium, which also reabsorbs water, and antidiuretic hormone, which reabsorbs water without affecting sodium levels. Okay, so these will keep water. We want to block them. Okay, so that'll help get rid of some fluid volume. But vessel tone is also going to be contributed by things like norepinephrine. So again, a beta blocker could help with that. But stronger things that contribute to vessel tone are things like angiotensin 2, which is a very powerful vasoconstrictor, and again, ADH, because the other more famous name for ADH is vasopressin, which is the strongest of all vasoconstrictors. So again, an ACE inhibitor can prevent that. But you could also use something called a calcium channel blocker, because a calcium channel blocker would block some of the contractile properties that we have of the smooth muscles and the vessel walls, right? So again, there's a lot of, you have to go back a lot to Anatomy 2 basics to understand why these things work. But once you understand the basics, it's not hard. It's very simple, actually. And vice versa. I mean, obviously, hypertension is going to be the thing you're fixing in most people, because chronic hypertension is going to lead to cardiomegaly, because we're having to overcome higher peripheral resistance, right? And there's this formula that basically says, you know, mean arterial pressure, which has to deal with blood pressure, is a reflection of cardiac output times total peripheral resistance, right? So if I'm increasing resistance, that's going to increase blood pressure. If I'm increasing my heart action, that's going to increase blood pressure. So one way we could take down blood pressure is by relieving, you know, some of the things that would naturally resist, like vessel tone, right? If I get rid of some of the tone, which makes vessels too hard, that's going to lessen the blood pressure. But what if my blood pressure's too low, right? What if blood pressure's too low? Then I'm hypotensive, right? We certainly don't want to do those things, do we? If I'm hypotensive, I definitely don't want to give somebody a, you know, ACE inhibitor. I definitely don't want to give them a beta blocker. I want to increase the presence of angiotensin 2. I want to increase the presence of vasopressin. I want to increase the presence of norepinephrine. So give it to them, right? So give them fluid, you know, give them vasoconstrictors. So you would do the exact opposite. But again, once you know the basics, everything becomes kind of simple. When it's going this direction, go back in the other directions. That's how homeostasis works, right? The body naturally does it on its own, but when the body's broken, that's where we come in. If the body can't fix it on its own, what would the body have naturally done in this situation? Well, it's not able to, so let's go ahead and do it for it, right? So give the patient vasopressin, give the patient fluids, give the patient blood if that's what they're losing, right? But if they're peeing themselves to death, you know, you don't want to give them whole blood necessarily, because maybe they have some type of diabetes insipidus, right? You just have to replace the fluid because they're losing very dilute fluid. You don't want to give them whole blood because that's not dilute, right? But anyway, give them fluid. That makes sense. Give them some vasoconstrictors until that fluid absorbs. but it's not hard. It's just, again, you have to have a strong understanding of the basics. And I don't expect anybody that looks at this to begin with to say, oh yeah, this makes perfect sense. It doesn't. This is what's called like a mind map of all the stuff that we've talked about. This is like a mind map of everything. So it takes a while to even understand what half this crap even means, right? Like that's aldosterone, antidiuretic hormone, angiotensin 2, sympathetic nervous system, adrenaline, parasympathetic nervous system, sympathetic nervous system, adrenaline. So it takes like a library of information just to figure out what all the abbreviations stand for. But here, cardiac output equals stroke volume times heart rate. That makes sense, right? So how can I increase cardiac output? Well, we can make the heart beat faster, right? Or we can decrease cardiac output by making the heart beat slower. That's not too bad, right? I can increase cardiac output by making the stroke volume go high, or I can decrease cardiac output by making the stroke volume go lower. Right? So it's just showing all the factors that can go in to alter these things. Right? And if you're pushing blood out of the heart, right, into a highly resistive body, you're going to have very high blood pressure. That makes sense too, right? So sometimes this is too high and we got to fix it. So might not necessarily want to make the heart weaker, but maybe take some of the resistance away. And that's how we treat heart conditions too. So, you know, when you get into medications are usually just trying to treat one piece of the puzzle. But a lot of times, if somebody has some type of heart, let's say disease, how did they get there? Diet, maybe, lack of exercise, extra weight. And then all these things are going to also contribute to the likelihood of getting diabetes, which is going to make it worse for everything, right? It's going to be a compounding factor. And so ultimately, if I want to treat sequela of heart disease, because look, I can get coronary artery disease that leads to a myocardial infarction, that leads to cardiomegaly, right? That leads to congestive heart failure. So how did I get this to begin with? Well, it's probably genetically predisposed, but diet didn't help. Lack of exercise didn't help. Too much weight didn't help. So we want to get rid of these, right? Or increase diet, you know, start exercising more, increase exercise, decrease weight, right? That's going to make this less bad, decrease the likelihood of further complicating with these, take some pressure off the body. So if this already exists, again, it didn't have to come from this sequence of events. This can exist in the absence of all these, right? But if I decrease my weight, I don't have as much resistance to the heart to begin with. So that'll take off some pressure that the heart has to go against, right? If I make the heart beat more efficiently per beat, which, you know, some aerobic exercise can help with that. That would help. So a lot of times when you're treating heart conditions, you're treating underlying factors. Like, do they have proper diet? Are they exercising? Are they the proper weight? So that's why that just gets hammered all the time. And, you know, what are other things that can contribute to resistance is stress. So we want to decrease that, because the more stress we have, the more sympathetic tone we have. So increase diet, get more exercise, lose weight, stop stressing out, but not always possible. So then medications and interventions come in. But once the heart has been damaged through a heart attack, it's not going back. Once the heart has grown into cardiomegaly, it's not going back. So at that point, this is what's going to kill you. How fast do you want to die? Really fast? Then keep having a bad diet. Keep not doing exercise, keep gaining weight, and keep doing stressful things. That'll speed that up for you real quick, right? But if you want to live a little bit longer, then you have to do these things, right? Along with medication, if it's already gotten to a point of no return, which obviously if this exists, then it's already there. But again, we can decrease how quickly it progresses. So let's stop there. I think that's a good tie-in. All the stuff ties in fairly well. Again, we'll talk about atherosclerosis, arteriosclerosis when we get into the vessels next week. But one thing that I did want to go over, again, valves and murmurs. So I'll go over this with you at the beginning of next week's material. So Next week, before we get into blood flow and pressure, I'll come in and I'll do that last little bit of cardio-phys right there. So we'll talk about valves and murmurs, and then we'll jump into blood flow and pressure. And one of the first things we'll do with that is just capillary, how the capillary works again. And then we'll talk about properties of arteries versus veins, and then different diseases like peripheral vascular disease, peripheral artery disease, stuff like that. But that is good for today. So that'll end it for this week. So this was our Zoom meeting for 6/22. I'm going to go ahead and stop the recording so we can go ahead and start to consolidate.